Okay, my name is Chuck Vogel, and I was born in 1938 in Rockaway Beach, New York. It's a peninsula that's 3 blocks wide, and I lived on 130th Street, 1 block from the bay, 2 blocks from the ocean. Growing up, my dad was a pharmacist and had a pharmacist in the local area in the era when there were still mom and pop pharmacies. My mother actually started out as a concert pianist, but got to the point where she felt emotionally she just couldn't do it. The stress was too much. And so she taught piano really for the rest of her life. And growing up, I grew rather rapidly, so I was the biggest kid in the class, which seems kind of weird at this juncture. And I was very athletic, and because I was so big, I jumped center in basketball. I played first base on the baseball team, and in the police athletic league, I was one of the better hitters, and I stole every base that I could steal. Basketball, I played pretty well and made it to the first cut on the Princeton freshman basketball team, the last cut actually. But growing up, it was mostly athletics and scholastics. Religion played a big part of my life early on, and when I was preparing for my bar mitzvah, I had a very, very good voice, and it grew to the point where I actually sometimes took the place of the cantor if the cantor was sick in the temple. Over time, I became far less religious, probably after I went to Princeton, started questioning everything about organized religion, and really not practicing at this point in time. I wanted to be a physician from the time I was very young. I don't know whether I was brainwashed, which is what my sister says, but every book that I read was a medical book from the time I was probably 6 or 7. I can remember Microbe Hunters and Men Against Death by Paul de Kruif. And it was that type of books that I read. So I always wanted to be a physician. I didn't know what kind, what I was going to do. When I was early in my career at Yale, I thought I wanted to be a physician in Appalachia. That changed. There was no such thing as oncology in 1960. I mean, I took the first oncology boards in 1973. And just skipping ahead, I was really the first true medical oncologist trained at the Solid Tumor Center, at the Solid Tumor Service of the National Cancer Institute. But we were just starting to transition in the early 1970s to starting to think about treating solid tumors. And in 1969, Cooper published a paper in 5-drug therapy for breast cancer. He didn't publish a paper. He published an abstract that Jim Holland eventually embellished upon about 10 years later and wrote up Cooper's abstract on CMFVP. But anyway, that was just one thought, and people were starting to try to think about giving chemotherapy drugs to patients who had cancer. And back then, the only oncologists were hematologists, because they knew how to treat leukemia, lymphoma, so they knew how to deal with anti-cancer drugs. There were no pure solid tumor medical oncologists. And I decided at the NCI, because I was going to go off to Uganda anyway, that I wasn't going to take 3 years fellowship for that would make me heme and onc boarded. And so when the boards came out, I could only take medical oncology boards, the very first ones in 1973. And I've been grandfathered in ever since. I wanted to start an oncology ward at Grady, and that is what I wanted to do. And so I came back and gave up my commission in the United States Public Health Service, and in 1973 went to Grady. So I treated lymphoma and leukemia from 1966 to 1969. And in my stead, John Ziegler went to Uganda, and he started the Uganda Cancer Institute, which still exists to this day and is thriving under the direction now of the Fred Hutchinson Cancer Center. But back then it was an NCI endeavor. And John came back and he showed pictures of his home, which was probably better than any home that I could ever afford in my lifetime. Beautiful place with five servants, somebody to take care of the kids, a housekeeper, and a cook, and a night watchman. And so I went to my wife, who was pregnant again, and said, "Hey, you want to go to Africa?" Because now I was being asked, because of the success of John and his research in Burkitt's lymphoma and childhood Hodgkin's disease, they said, what about some of the endemic solid tumors in Uganda? And so my wife liked the idea of having 5 servants, and so we decided to go to Africa. Stacy was 2, and Brian was 6 months. Got on a plane and went to Uganda. The patients would come in from all over Uganda, and if we had 16 beds, we had 50 people, because they would bring mats and they would sleep under the beds of their family members. So it was always very crowded. And there I started working primary liver cancer and became, at that time, the world's expert in primary liver cancer. Kaposi sarcoma, which in the United States nobody cared about. It was a disease that affected very, very rarely little old Jewish men and little old Italian men, and little bumps on the legs. In Uganda, it was an endemic. So I saw 200 cases, had 200 cases of hepatoma. And we also treated malignant melanoma, which was very different there. It was mostly on the soles of the feet and the palms of the hands. And there was a guy from pathology who went around Uganda and washed the feet of 5,000 Ugandans. And Ugandans have pigment spots on the soles of their feet. And some tribes, there was a predominance of those pigment spots on the back, towards the heel, and in others more towards the toes. And he then mapped out where the melanomas were, and he found out that it was tribally determined whether they would be on the ball of the foot or on the heel of the foot, based on where the pigment spots the different tribes had. So that was interesting. I didn't do that, but it was sort of an interesting observation. But I started working on BCG. Georges Maté was a very famous French immunologist, immunotherapist, and he was using BCG to treat melanoma. So that was the start of immunotherapy of melanoma, really. Probably the most important paper that I've ever published in my life is long forgotten by everybody, and that is that we were the very first to describe the link between hepatoma and the hepatitis B virus, which at that time was called the Australian antigen. Gordon Zubrod was assembling, at that time, the brightest minds in solid tumor oncology. We had Paco Tejada, who was doing head and neck cancer, Larry Broder was doing, and Oleg Solari were doing lung cancer, but he didn't have anybody to do breast cancer. So he said, Chuck, I would like you to come down here and be my chief of breast medical oncology. And I said, Gordon, that's a great honor, but I know absolutely nothing about breast cancer. I haven't treated breast cancer hardly ever. I never saw breast cancer in Uganda. It was a relatively rare disease there. And even at when I was at Grady, I really didn't see all that much breast cancer. And I said, are you sure you got the right guy? He said, this is the early phases of solid tumor chemotherapy, and nobody knows anything about breast cancer. So I know that you can develop research programs. So why don't you come down and be my chief of breast medical oncology? Something became very apparent to me, which was that we were training a huge number of fellows who were going out into private practice. And they were good. And all of the patients didn't want to go down to Miami. They wanted to be treated in Boynton Beach or Jupiter or Naples or wherever it was. And so all of the research protocols are at the University of Miami, and all the patients are in the community. And so I went to the powers that be at the university and said, we really have to have a community outreach program. And the university lawyers said, no. They said, we're concerned about the litigious nature of our community, and it's asking for trouble, and no, we are not going to have a community outreach program. So at about that time, I always sort of had itchy feet and sort of try to move on to some place that I thought had greater potential. And by 1986, it had become apparent after 11 years that whereas I thought the next year we would be MD Anderson Southeast or Memorial Sloan Kettering South, I didn't think we were going to get there, and certainly not in the next decade. And that's sort of how I sort of made my decision at Emory. You know, is this place going to become a major place in the next decade? And I said no. And at about that time, a guy by the name of Bernie Salek came along, and he had this idea of having community cancer centers with 24-hour, around-the-clock oncology care. And I was his second medical director. His first one was Jerry Rosen, who was, at that time, one of the biggest names in sarcoma research in the world. And so I left, and I actually then, over the space of the next 3 or 4 years, worked at Parkway Regional Medical Center, what was then AMI Kendall, JFK, Mount Sinai. And so I was working at 4 outpatient cancer centers. And in the meantime, I asked Salek, I said, I want to build a clinical trials network. And Salek was under the influence of Jerry Rosen, who, although he had come from Memorial Sloan Kettering, had never been in the mainstream of doing conventional cancer research as we know it. And so I wanted to bring common cancer research methodology to community care, something that was not being done. Maybe it might have been started and done also by Greco and Hainsworth up in Nashville. I don't know whether they were before me, after me, the same time. I think I'm older than they are, so maybe it came a little after, but I don't know. But there was no community oncology as such. So I went to Salek, and he loaned me $15,000. And with that $15,000, I purchased part-time the services of a nurse, Cynthia Frankel. And Cynthia and I, over the space of the next 2 to 3 years, built a community network consisting of 100 medical oncologists in, probably 20 different communities. And we put 1,000 patients on clinical trials from within community practice. Well, Herceptin is probably really the highlight of my academic career. Not that I deserve a huge amount of credit for it. I was a worker bee, really. There were several of us who had the patient resources to accrue to the early clinical pivotal trials. And so I was in the Herceptin arena, not from the very beginning, because that was really only Mark Pegram and Denny, and actually the first publication was Jose Baselga's in terms of treatment, and that was a ho-hum article in the JCO, because they didn't choose on the basis of HER2 positivity, and they come up with an 11% response rate. And so a JCO article with an 11% response rate, and at that time, nobody paid much attention to the Baselga article. But I said, gee, if you're getting any responses in patients with widespread disease, I think that there's something to this drug. So I really wanted to study it. And I was in the Herceptin story from there on. And I actually thank a gastroenterologist for that. Cynthia and I met with Tom Twaddell, who was running the pivotal trial, first person to run the pivotal trial. And I guess Tom gets a bunch of bad breaks because the pivotal trial got off to a very slow start, and they didn't listen to the advisory board. We had an advisory board in Annapolis, Maryland, I remember distinctly. And I remember distinctly that one part of the protocol that was we had to do rectal exams and stool guaiacs on everybody, probably because Tom was a gastroenterologist. And there are a lot of other things in the original design that were really not very good. And so the pivotal trial got started, and along the way, 2 other trials. The trial eventually published by Melody Cobley, and the other trial that I published on first-line single-agent Herceptin. And all 3 of those trials were running concurrently. And the next person to take over from Tom Twaddell was Hank Fuchs. And Hank made some major changes in the protocol, started to listen to the investigators, and accrual started to increase. And then Steve Shack came along, and Steve really got things moving. And I think that I really had a bit of a pivotal role to play there, because I made a trip out to California, and I had been a skeptic about Herceptin, because I had lived through C. parvum and I had lived through Corynebacterium, C. parvum and BCG and quote immunotherapies. And so I was skeptical until the first couple of patients with liver and bone metastases come in wheelchairs and walk out. And so I went to see Steve and I said, Steve, do you guys know what you have? I said, you don't see this in metastatic breast cancer from a non-chemotherapy drug and with the rapidity of responses. And at that time, Levinson, who was the head of Genentech, was walking by Steve's office. Steve dragged me into the hall, and at the time, Genentech was trying to decide whether or not they were going to build another factory to make enough Herceptin to finish the pivotal trial. And he said, you tell him what you told me. And I just told him, I said, this drug is going to be very, very good. And the rest is history. I mean, I published my first line single agent Herceptin paper. And, although the response rate was 26%, everybody forgets, except for Melody. Melody never forgets. And Melody still uses a lot of first line single agent Herceptin. At least she was last time I talked to her. We had a 50% clinical benefit rate in that trial. And I actually have slides where I compare the overall survival in my first-line single-agent Herceptin trial and the pivotal trial. And the overall survivals are the same. And so first-line single-agent Herceptin, really went nowhere. But I certainly traveled the world speaking on that. And I was a second author on Melody's paper, and Melody was the second author on my paper. So between Melody, myself, Deb Tripathy, and Lou Fehrenbacher, we were the worker bees. I mean, Slayman, of course, was the godfather, and Mark Pegram was an absolute genius working by Slayman's side. And he still is a genius. They both are. And I don't put myself in their class as clinician investigators. But I was in the right place at the right time. I got a break that Tom Twaddell was giving this little community oncology group the chance to study Herceptin. And published quite a bit on Herceptin, and it was a very, very exciting time, and continues to be. Anti-HER2 therapy continues to evolve, and I've been involved in every one of the anti-HER2 drugs that has come to market in terms of their clinical trials development. We were doing research with Amgen on Neulasta. And they designed the clinical trial of giving 100 milligrams of Taxotere per meter squared to patients with metastatic disease, and they wanted to see whether Neulasta would reverse that. And they couldn't accrue the trial. And so we went to an advisory board meeting, and I was standing in the back of the room, and they were bemoaning the fact, why can't we accrue this trial? And being the brash, outspoken person I'm not anymore really. I said, because study design is stupid. And I said, you've got to make changes. You have a made-to-order population of patients. Nobody in America gives 100 milligrams per meter squared of Taxotere to metastatic disease patients. But we are giving it in the adjuvant setting. Add that, and you'll accrue your trial. they accrued the trial, and I wasn't one of the major accruers to the trial. And to this day, you cannot turn on a television set without hearing those data, which are my data. And the Amgen people still refer to that as the Vogel paper. And basically, it showed that if you give Neulasta, it decreases the risk of febrile neutropenia from 17% to 1%. And I turned on television the other night, and in the Onpro commercial, 17% to 1%. So that's the long and short of really the Neulasta story.
Hey Chuck, I'm sorry I can't be there. This is Hymus, one of your old friends, probably a guy almost as old as you, or it could be worse, but still practicing and seeing patients and doing research and trying to follow in your tradition. You've been a great friend, a great advocate for so many women with breast cancer, and you've done terrific research in your lifetime. You taught us all about trastuzumab, capecitabine, and lots of other stuff, and you're always in our emails for tough cases. So I don't know if you're retiring. I hope not, maybe cutting back. If you are, I wish you the best, but I hope you're not, just cutting down a little bit. And many good, healthy years to come with family, with patients, if you're still gonna be doing that. And it's been a privilege for me to know you and consider you a friend. You're a terrific guy, and you've done so much for our field. So sorry to miss it, best, and happy to do anything I can to help you in the future as you transition and do other things.
Chuck Vogel, it's so nice to see you, and we really wish we could be there with you, but we're trapped here in Shangri-La. I'm sorry, I mean Palo Alto. Sometimes I get those mixed up. Easy to do. But we want to congratulate you on being a legend of oncology, and that is truly an overdue award indeed. I remember working with you in the early, mid-90s together on the project called Herceptin or something like that. Was it called Herceptin?
Who ever heard of that drug?
But I can tell you what, Chuck, your contribution to that project was seminal, along with Melody Cobley, because back in those days, as you know, there were several near-death experiences of that project. And it was the clinical data, your clinical observations and Melody's clinical observations and your seminal papers that won FDA approval even for the single-agent indication that carried the day in those dark ages when we were wrestling with cardiotoxicity, with pulmonary kind of infusion, anaphylactoid type reactions. Both of those, by the way, made articles in Circulation where the cardiologist said we probably shouldn't develop the drug for cancer. And the front page of the San Francisco Chronicle articulated the pulmonary infusion reaction problem. And so those were dark days. And Dennis Lehman used to always tell me how fortunate we were to have great clinicians involved in this project, because that was the only credible, believable data for many people back in those days, and it made a huge contribution to science, to clinical investigation, to patient care, and so I thank you for that, and it's been a pleasure to work with you over the years on that and many other projects. The other anecdote I'll tell was, as soon as I got back to Miami, I made it my mission to bring you and MJ back into the University of Miami fold, and so that was my major accomplishment as a faculty at UM, to get you guys up there at Deerfield and basically take over. And you've done a remarkable job there, and the patient care and everything, the quality of the program up there is absolutely exceptional. So thank you, congratulations, and it's a pleasure working with you. I look forward to working with you in the future.
And Chuck, George Sledge here. I think I've known you even longer than Mark. I date back to the days of the old Southeastern Cancer Study Group, my first oncology group, where you played a pivotal role in terms of the direction of the Breast Cancer Committee, and where you were a legend in your time in terms of new drug development for early stage breast cancer. You were a force to be reckoned with. You were someone who those of us who were young clinical investigators looked up to, you were someone who clearly mattered in terms of the world of oncology. So this honor is well deserved. Congratulations, and thanks again for all that you've done for our community and for our patients.
Okay, on this next take, George, maybe you could give us some more emotion. You know, kind of like Bill Shatner in Star Trek, like Captain Kirk. You know, can you give it a little bit more drama on the next take? So we'll.
We're gonna have another take.
Yeah, we're doing multiple takes.
Okay.
So